the explanation I give most of my patients that have fit the criteria to have a transoral incisors fundoplication. It helps when you're an old geezer like me. What I tell them is that this is the normal patient. This picture here is what a normal patient looks like. This being the esophagus, this line being the junction between the stomach and the esophagus, we call that the GE junction, and this being the stomach. This line here represents the diaphragm. I ask them if they understand what the diaphragm is. When they do, I tell them it separates the chest from the abdomen. And I said, what keeps all of us from refluxing? Because this is a negative pressure. And I remind them about a sucking chest wound. If you put a knife in a chest, you hear this sucking chest wound. So it's a negative pressure. And then I tell them this is negative also, but it's so much less negative, we'll consider it positive. And if it weren't for this mechanism, everybody would reflux. And that mechanism is this distance from the diaphragm to the GE junction, this angle from the esophagus to the stomach, and a valve that's right here. And that all those things in a normal person prevents reflux. And then I tell them that their particular problem that I've worked up now and proven by biopsy or x-ray or pH studies, whatever, is that they have this esophagus and this junction of stomach and esophagus above the diaphragm. And so that protective mechanism is all destroyed and they reflux. If they take medication to stop the reflux, it does not stop the reflux. It stops the acid in the stomach, but it doesn't stop the reflux. They will still reflux. And in order to prevent reflux, it has to have an anatomic correction to bring it back into that type of picture. And then I take this towel to explain it to them. I said, maybe I can do it by... I take this towel and I explain to them that, you know, hiatal hernia surgery has been out for 50 years, and the original surgery was devised in order to... Then I tell them that the surgery to correct that anatomic defect has been around for many, many years. It was devised by Dr. Nissen, and that operation is a big operation. It entails making a long incision in the abdomen and reaching our hands up behind the heart to encircle the esophagus and pull it down and repair that hernia. And I explained to them, this is how it works. If you can see this as the esophagus and this as the stomach, we put our hands around that esophagus, break up all those attachments, those natural attachments that hold that esophagus. We break that up, pull it down below the diaphragm, and then wrap the stomach around the esophagus, and that's what it looks like. And it works in about 86% of the patients. It changes that angle, it changes that distance, this distance below the diaphragm, and it makes a new valve right there that stops the reflux. And it works great, but there's a problem with it in that everybody that has the operation, because it's a tight wrap there, everybody that stops their reflux, it also stops their ability to belch and their ability to vomit. 80% of the patients put up with it for the rest of their life, and there's 20% that just cannot put up with it, and they have a lot of problems. They bloat, they fart, they pass gas in church, they're very unhappy with it. But it stops the reflux. And like I say, if we tell them all that, 80% of them are satisfied, 20% are not. Well, technology advanced and we were able to do it with the laparoscope. And it was the same procedure except done laparoscopically. Instead of our hands, we put these devices, we go around the esophagus, pull it down, wrap it around, and it's the same operation. And it works, not quite as well for some reason, we don't know. But it does work because the anatomical changes are made. But these patients also have the same problems. They all have problems with not being able to belch or vomit, and they pass a lot of gas and they have a lot of gas discomfort. But it does stop reflux. Technology is now advanced so that in the last 5 to 7 years it's been done endoscopically. We've been doing it here for the last 2.5. And we have 150 patients that we've done this surgery to. Some of our patients are being studied and some of them are being published. And what that operation now entails, instead of making an incision of any kind, instead of disrupting all these tissues, we go down through the stomach with the endoscope, if you can imagine that. We have an attachment on the device. It pulls the esophagus down below the diaphragm, and then it folds the stomach up. And so there you have it. It looks exactly like the other, except the difference being it's not 360 degrees, number one. Number two, there are 20 sutures underneath here that hold it together. So it's actually very robust. You have this distance, this valve, you're down below the diaphragm, you have this angle, and now all of our patients don't have any problems with vomiting or burping. They can still belch, they can still vomit. I've not had, out of the 150 patients that I've done, I've had none that have complained of gastric fold syndrome or any problems post-operatively. We've had no intraoperative deaths, no immediate post-operative deaths, no long-term deaths. And so, procedure is done for the welfare of my patients, for their benefit and for their health. And I feel it's safe and very effective.